Usually, like when you're driving and a red check engine light suddenly flashes on your dashboard, your heart kind of skips a beat.
Oh, yeah. It demands your attention immediately.
Right. You just instinctively know you have to pull over or, get to a mechanic to fix it.
Because it creates this immediate sense of urgency. I mean, that single light is specifically designed to be impossible to ignore.
But imagine for a second that you're driving, and instead of one light, your dashboard has 50 different check engine lights.
That sounds like a nightmare.
It really is, and they are all flashing red at the exact same time, with the exact same blinding intensity.
Wow. Yeah, I mean, if everything is an emergency, then literally nothing is. You wouldn't even know where to look.
Exactly. You'd probably just want to abandon the car entirely. And honestly, that terrifying blinding dashboard is a pretty accurate representation of what the future of healthcare looks like right now.
If the industry doesn't radically change course, yeah. Which brings us perfectly to the core of today's deep dive.
Yeah.
We are exploring this fascinating working white paper by Dr. Frank Giapelka.
It's titled From AI Loops to Patient Goals, right?
Yes, and he's taking us much deeper into the concept of patient-driven, goal-directed care. Because, the medical field is incredibly excited about artificial intelligence right now.
Oh, for sure. Everyone's pumping out algorithms that can predict disease and monitor vitals and all that.
Right, but Dr. Opelka points out that by just throwing AI at our current system, we might actually be creating a massive new problem in the process of solving an old one.
And the fundamental issue here revolves around something called loops.
Yeah, let's unpack that.
So a loop is basically a closed cycle of care. It starts by sensing a signal like, say, a change in your heart rate.
Mm-hmm.
Then it makes an inference or a recommendation based on that signal, takes some kind of action, and finally verifies that the result actually happened.
Right, so it's not just a chatbot answering a quick medical question and then turning off. It's a relentless system that just keeps running until the work is definitively finished.
And in theory, building these loops is the correct response to the biggest failure mode in healthcare today, which is unclosed loops.
Exactly. I mean, right now, a doctor makes a correct recommendation, maybe for a follow-up scan, but no one ever actually verifies if the patient got the scan or what the results were.
So engineers are building AI loops to monitor absolutely everything.
Right. You have an AI loop watching your blood pressure, another loop to gradually adjust the dose of your diabetes medication, and, another loop sending reminders to ensure you get your routine cancer screening.
But here's where we hit a breaking point. Think about a patient managing multiple chronic conditions at once.
Which is very common.
Right. Suddenly you have a dozen concurrent, highly active loops running for just one person.
And then you multiply that by a primary care doctor's entire patient panel, which can be, thousands of people?
Exactly. So now you have hundreds of thousands of loops constantly pinging. That's our flashing dashboard.
It's overwhelming.
Yeah.
If every single one of those loops runs at full intensity, sending an alert every time a minor threshold is crossed, a doctor has no way of knowing what to focus on without totally burning out.
And Dr. Opelka recognized that we are building systems that maximize these loops without putting any kind of governor on them.
Right. We are optimizing the wrong quantity because we've fundamentally misunderstood what is actually scarce.
Because detection is cheap now, right?
Exactly. Detection is incredibly cheap. AI algorithms can spot anomalies all day long for pennies. Attention is what's expensive.
Yeah, that makes a lot of sense.
What is genuinely scarce is the clinician's capacity to drive a medical goal to completion, combined with the patient's capacity to actually absorb and perform the work being asked of them.
So to fix this dashboard, we can't just build smarter predictive models. We need two massive shifts.
Yes. A supply-side shift and a demand-side shift.
Right. The first is supply-side governance, meaning we need to build a machine that actively rations the doctor's attention. And the second is a demand-side cultural shift.
Moving away from a system where the doctor just issues orders to a system of true patient partnership.
Okay, let's start with that first shift. The machinery. To ration attention, we have to fundamentally change how we measure the healthcare journey itself.
Because right now, American healthcare is almost entirely built around the encounter. The 15-minute visit, the billable event.
Which is incredibly frustrating for you as a patient. I mean, you go into an appointment and you feel like you have to tell your entire medical history from scratch every single time.
Because the system treats that 15-minute window as a totally isolated event.
Right, because the encounter is the unit of fee-for-service accounting.
Exactly. Doctors are often paid per discrete visit, not for the overall outcome or the time they spend coordinating care behind the scenes.
So if we just attach powerful AI loops to the 15-minute encounter, we are simply taking a highly fragmented system and making it more efficient at being fragmented.
That's a great way to put it. The true clinical unit shouldn't be the encounter. It needs to be what Dr. Opelka calls the episode in the arc.
Okay, so an episode is a specific, contained journey, like a pregnancy or recovering from a knee replacement.
Right, or actively managing a flare-up of heart failure. It has a distinct beginning, middle, and sometimes an end.
And then the arc is the whole person container that holds all of your individual episodes together over time.
It's your life's overall health trajectory. Yeah. Care has to run seamlessly from encounter to episode to arc.
The paper has a great visual for this, the circle of arcs.
Yes, imagine a wheel. At the very center of gravity, the hub sits primary care. The primary care relationship is supposed to hold the whole patient arc and set the core conditions and goals.
And around that center hub are these concentric, co-equal outer rings.
Right. Those outer rings represent the specialties, so cardiology, oncology, nephrology, things like that.
But wait, I have a logistical question here. Doctors are already drowning in administrative tasks and burnout, right?
Oh, absolutely.
So if a primary care doctor is suddenly responsible for holding the center hub of this incredibly complex wheel for thousands of patients, doesn't the center just collapse under the weight?
That's a very real concern. When a patient has 6 different specialists and dozens of active episodes, how does one primary care physician juggle that without dropping the ball?
Exactly. It seems impossible.
Well, that structural vulnerability is exactly why the system relies on a concept called seating under load.
Seating under load. Okay, how does that work?
When a patient's complexity outstrips what the primary care team can safely co-manage, they don't just refer the patient away and hope for the best. And they definitely don't silently drop goals.
Okay.
Instead, an episode is deliberately handed off or seated to one of those co-equal specialist rings.
Ah, I see. So the primary care doctor holds as much of the overarching arc as possible, but priorities prevail.
Precisely. Handing off an episode becomes a conscious, track system choice with clear lines of authority, rather than just a failure of communication.
That makes sense. But even with a perfectly organized wheel of specialists, we still have all those individual AI loops running in the background.
Right, the flashing dashboard problem.
Yeah. We need a way to stop the dashboard from flashing all at once. And here's where it gets really interesting. The solution proposed here is to introduce an AI agent acting as a goal navigator.
The goal navigator operates on a totally different conceptual level than a standard medical algorithm. It makes goals, not the loops themselves, the fundamental unit of care.
Because a loop is just machinery and logistics, right? But a goal is a purpose.
Exactly. A goal is a target state, getting your blood sugar under control so you don't lose nerve function, or recovering your mobility after surgery.
Or even something highly personal, like wanting to remain independent in your own home for as long as possible.
Right. And a single one of those goals could have 20 different AI loops feeding data into it.
Wow. So the goal navigator sits downstream of all that raw loop data, but upstream of the doctor.
Yes. It acts as the ultimate arbiter of attention. It enforces an attention budget by implementing what they call a primary goal cap.
A primary goal cap, because human working memory has strict limits.
Exactly. A clinician can only meaningfully drive a handful of complex goals at any given time before their effectiveness just plummets.
So the navigator recognizes this biological limit.
Right, and it strictly limits the active foreground goals to 3 plus or minus 1.
Wait, really? So there is a hard absolute limit of 3 or 4 primary goals that a doctor is allowed to actively focus on for you at any one moment?
Yes. It is not a suggestion. It is an enforced constraint built into the software. It forces honest prioritization.
That is wild.
If a patient develops a new, severe condition that absolutely must become a primary focus, another existing goal has to step down from that top tier.
Okay, I picture this kind of like an air traffic controller at a major airport.
Okay, I like that.
The controller only has a limited number of runways. They can only clear a maximum of 3 or 4 planes to land at the exact same time. Those are your primary crises.
Right, and everyone else has to be managed differently.
But that actually makes me nervous. If my doctor is only allowed to focus on 3 planes landing, doesn't my basic preventive care like a routine cancer screening or my annual flu shot just get permanently grounded if I develop a serious chronic illness?
That is a brilliant question. And the fear that the urgent crowds out the important is very real in medicine.
Right, you don't want to fix the heart problem but miss the cancer.
Exactly. So to prevent that, the goal navigator categorizes every single goal into one of 5 explicit tiers. The active runway is just the primary tier.
Okay. What are the other tiers?
Below primary, you have the watch list. These are planes in a holding pattern. Conditions that are important and under careful scrutiny, but not quite critical enough to demand immediate intervention.
Got it.
Then you have maintenance for conditions that are currently controlled and stable. They're cruising comfortably at altitude.
And the preventative care, the cancer screenings, where do those go?
Those go into the 4th tier, which is called background and preventative. This tier acts as a protected lane.
A protected lane, so it can't be bumped by the primary goals.
By design, it cannot be starved of resources by acute demand in the foreground. Screening, immunizations, and healthy living goals run on autopilot on a population-wide cadence.
Oh, that's smart. So it operates completely independently of the primary cap.
Right. It sends automated outreach and scheduling without requiring the doctor's daily cognitive focus. And then finally, there's a 5th tier called deferred.
I assume that's for things parked for a later date.
Exactly, like a minor elective surgery. It's parked, but it's never abandoned or forgotten.
Okay, to make this concrete for the listener, let's look at the worked example from the source. Imagine you are a 68-year-old patient and you have a lot going on medically.
Let's hear it.
You have type 2 diabetes, you have heart failure, stage 3 chronic kidney disease, mild depression, you are taking 11 different active medications, you have an overdue colorectal screening, and you just had a knee replacement 6 weeks ago.
Which is a very realistic patient profile, honestly.
Right. Under our current ungoverned system, that is 10 or more separate alerts screaming at the doctor the second they open your electronic chart. It's just totally unmanageable.
Right, the flashing dashboard. So let's look at how the Goal Navigator's dynamic tiering organizes that exact patient.
Okay.
Based on that strict 3 plus or minus 1 cap, the primary tier might hold recovering from the knee replacement because that requires intense active physical rehab right now.
Makes sense.
It would also hold managing the heart failure because let's say there was a recent hospital admission for it and getting blood sugar under control, which currently requires active daily medication adjustments.
So that's our 3 primary goals. The active runways are full. What happens to the kidney disease and the depression?
Those would sit on the watch list. They're being closely monitored by the AI loops, but they aren't the acute focus today.
Okay. And blood pressure and medication safety are down in maintenance because they're stable.
Exactly. Meanwhile, the overdue cancer screening is sitting safely in that protected background lane, automatically running outreach to schedule an appointment.
And maybe a goal for structured weight loss is deferred until the knee is fully healed and you can walk comfortably again.
You've got it. It creates a beautifully clear, organized picture of health. But human physiology isn't static, right?
No, it's always changing.
Right. So imagine a routine lab test comes back a week later and shows this patient's kidney function is suddenly rapidly falling.
Okay, so the AI is constantly pulling that real-time lab data and cross-referencing it against specific thresholds set by your care team.
Yes, and when that kidney function number dips below the safe line, a tripwire fires in the algorithm.
A tripwire, I like that term.
The Goal Navigator automatically promotes the kidney goal from the watch list up to the primary tier.
But wait, because of the strict attention cap, something has to leave the active runway to make room for the kidney goal, right?
Yep. Exactly. The system analyzes the recent data, sees that the patient's blood sugar has finally stabilized over the last few weeks, and it automatically demotes the glycemic control goal down to maintenance.
That is incredible. So no human doctor or nurse had to manually notice the kidney drift in a sea of raw data.
Right. And crucially, no preventive work was dropped to make room for the new crisis.
The clinician's attention just followed the patient's changing physiological state automatically, smoothly shifting focus to where it was needed most.
It's a huge operational upgrade.
But surely the algorithm must run into tiebreakers. I mean, if 2 conditions flare up at once, how does the machine actually calculate which goal gets the top spot on the runway?
That's a complex piece of engineering. The logic relies on several mathematical ranking factors. First, it evaluates time sensitivity.
Meaning how fast irreversible harm will occur if the condition is ignored.
Exactly. Then it calculates the cost of a miss, which weighs the severity of the consequence.
Like, a fast-moving skin rash might be highly time-sensitive, but the cost of a miss is pretty low.
Right. Whereas a slow-growing cancer isn't highly time-sensitive day to day, but the cost of a miss is catastrophic.
Okay, I see.
It also looks at the current trajectory of the disease. But the most crucial ranking factor, and this bridges us to the cultural challenge Dr. Opelka outlines, is patient priority.
Patient priority.
Yes, the goal navigator is fundamentally designed to factor in what the patient values most.
And that brings us to the demand side dilemma, because the engineering behind the machine is elegant. But if you just drop this highly sophisticated goal navigator into our current healthcare system, you are going to get a lot of blank stares from patients.
Oh, absolutely. The entire framework presumes that a patient actually wants to author their own goals and actively direct their care.
And historically, American medicine has not operated that way at all.
No, we have to reckon with a deep paternalistic inheritance. For generations, the medical model has been incredibly straightforward. The doctor commands, the patient complies.
The doctor holds all the knowledge and authority, and the patient is essentially a passive recipient of interventions.
Right. But Dr. Opelka makes a really sharp observation about this dynamic.
Mm.
This paternalism isn't just something imposed from the top down by arrogant doctors. It is co-produced by both sides.
Co-produced. That's fascinating. Because over a lifetime of rushed 15-minute encounters, patients have been explicitly taught to defer.
Yes, they've learned the script.
Mm.
You went to medical school. You know best, doctor.
And frankly, doctors who are burned out carrying massive cognitive loads and severely pressed for time find a lot of comfort in that deference.
It's significantly faster to just write a prescription and give an order than it is to negotiate a shared health goal.
Right. The patient avoids the heavy burden of medical responsibility, and the doctor saves precious time. It's an equilibrium, even if it's a broken one.
Exactly. To reframe this division of labor, the text distinguishes between two very different questions. What's the matter with you versus what matters to you?
I love that distinction. It makes me think of building a custom house. The clinician is the architect and the structural engineer. They are the absolute expert on what is medically possible.
Just like the engineer knows which walls are load-bearing, what materials meet safety codes, where the plumbing can go.
Exactly. But the patient is the homeowner. And only the homeowner is the expert on how they actually want to live in the house, what their daily routine looks like, what they value.
Right. If the engineer builds a house without asking the homeowner how they live, it might be perfectly structurally sound, but it will be absolutely miserable to live in.
The doctor knows the clinical constraints. You know your life priorities. High-quality care requires both experts to participate.
It really does.
But this raises an important question. If we redesign this entire AI infrastructure around patient goals, do we just force everyone to suddenly become the CEO of their own health?
What do you mean?
Like, what if a patient doesn't want to be the homeowner? What if I am exhausted, terrified by my diagnosis, and I just want my doctor to tell me exactly what pill to take and what to do?
We absolutely cannot force an activation agenda as a universal mandate. That's a huge point in the text.
Because some people just aren't ready for that.
Right. Validated psychological tools, like the control preferences scale, demonstrate that patients fall on a very wide spectrum of desired engagement.
So some people desperately want to lead their care and research every single option.
And some want to share the decision-making equally. But a significant portion of patients genuinely, sincerely prefer to delegate all authority to their doctor, especially when they are vulnerable or in pain.
So if the system dictates you must participate, you must set goals in the app before we treat you, we're just creating a brand new digital form of paternalism.
Exactly. We are forcing a specific behavioral model onto people who don't want it. It will inevitably backfire and earn the resistance it deserves.
It's just replacing one mandate with another.
The aim of this technology isn't to conscript every single patient into medical activism. It's to offer robust agency to the many who want it but have never been asked, while fully honoring the choice of those who decline and prefer traditional delegation.
Okay, so if we can't mandate patient activation, how do we systematically build it? So the Goal Navigator actually has patient input to work with.
Well, activation itself has to be engineered as a loop. You don't build engagement by handing a patient a tablet on day one and asking them to author their grand 10-year life goals.
Right, that's just intimidating.
You build it with scaffolding, using small, safe, low-stakes invitations. Dr. Opelka refers to this as the activation ladder.
The activation ladder. Okay, so imagine you're sitting on your couch looking at a health app. Instead of a massive blank text box asking for your life philosophy, the app asks a simple multiple choice question.
Right. Something like, What is your biggest concern about your upcoming knee surgery? A, pain management. B, time away from work. Or C, ability to walk my dog.
So it starts with a very concrete, simple
The,
preference.
the critical step happens next. When you state that preference in the app and you walk into the doctor's office, the technology must visibly reshape the clinician's actual workflow based on your input.
Ah, so if the doctor opens the chart and says, I see your top priority is getting back to walking your dog, let's tailor your physical therapy schedule around that, the loop is successfully closed.
Exactly. It proves to you that your voice matters and directly influences your care. It's the clinician's visible endorsement of your input that signals this isn't just administrative busy work.
But if that loop runs in reverse, the damage is severe. Like if a portal repeatedly asks me what my goals are and I take the time to fill out all the forms.
And then you go to your appointment and the doctor clearly hasn't read any of it.
Right. And just launches into a generic lecture. I mean, I learned very quickly that participation is purely theater. I will retreat back to silent deference, probably more cynical and firmly detached than before.
That's why the technology has to be incredibly smart about when it even initiates that loop. The
Yeah.
navigator must sense your readiness.
How does an AI sense readiness?
It evaluates the clinical moment by pulling data from your chart. If you just received a new diagnosis or you were just discharged from the hospital, you are likely hyper-aware of your health.
That's a teachable moment. So readiness is high.
Right. But if you are 6 months into a perfectly stable routine with no medication changes, asking you to set new goals is just annoying.
Yeah.
Readiness is low.
And the system also has to estimate your life bandwidth, right?
Exactly. If your chart indicates you are navigating a severe illness while managing multiple dependencies, the system should lighten the administrative, not add to your cognitive burden.
Okay, so what does this all mean for the big picture? Because I have a major pushback on this entire vision.
I'm all ears.
When I hear about this highly interactive, goal-setting technology where patients are managing their care trajectories through apps and portals, my mind immediately goes to equity.
Yeah, that's the big one.
Doesn't a system like this inherently favor people who are already health literate, wealthy, speak fluent English, and have the free time to manage a health app?
Yes.
What about the people working 3 jobs who are barely scraping by and don't have the bandwidth to climb an activation ladder?
Dr. Opelka outlines this as a massive systemic risk.
Yeah.
There is a well-known concept in public health called the inverse care law.
The inverse care law, what is that?
It states that the availability of good medical care tends to vary inversely with the need for it in the population served. In plain terms, those who need care the most are historically the least likely to get it.
And deploying advanced technology usually makes that divide worse, almost by default, doesn't it?
Unfortunately, yes, because digital engagement tools consistently work best for the already activated and highly resourced populations.
So if the AI loops and goal navigators are designed with the assumption of a tech-savvy, highly engaged user, this entire system will just become a digital reprise of the inverse care law.
Exactly. It'll accelerate care for the privileged while widening the very health disparities it hopes to close.
So how do we counter that?
The design discipline has to be inverted. The technology must be designed for the least activated, least resourced patient first.
So the interface has to use plain language, the barriers to entry have to be zero.
Right. And the industry has to be ruthlessly honest about what technology simply cannot do. An algorithm cannot manufacture human trust.
An app cannot dissolve the structural barriers of poverty or a lack of reliable transportation.
And crucially, AI cannot fix the fact that a doctor is trapped in a financial model that only gives them 15 minutes to see a complex patient.
Right. If the underlying payment structure continues to punish a doctor financially for taking the time to have a meaningful conversation about a patient's life goals, no software in the world can override that reality.
The structural and payment reforms have to happen in lockstep with the technological ones.
Okay, so to bring all these pieces together for you listening, fixing the future of healthcare AI isn't just about feeding more patient data into a machine to make better predictive algorithms.
No, it requires a profound two-part shift. First, we need to engineer governed, episode-based loops utilizing tools like the Goal Navigator that actively cap the noise, enforce an attention budget, and protect the doctor's cognitive capacity.
And second, we have to use that freed up attention to invite the patient into a true partnership, utilizing the activation ladder to offer agency without ever forcing it as a mandate.
Projecting this vision into the future leaves us with a truly profound challenge. Let's imagine that in 10 or 20 years, this technology is perfected.
The AI successfully manages all the grinding medical logistics of our lives.
Exactly. It completely removes the burden of tracking labs, titrating medications, dealing with insurance auths, and scheduling screenings.
The dashboard is finally clear of all those blinding red lights.
But when the machine clears away all that logistical noise and perfectly stabilizes your baseline health, it leaves us staring at a much harder philosophical question that we can no longer hide from.
Which is,
What are we actually trying to stay healthy for? If the machine turns to you and asks what your ultimate life goal is so it can align your medical care to achieve it, are you ready to answer?
wow, that is the ultimate question. Because once the emergencies are handled and the dashboard is quiet, you still have to decide where you actually want to drive the car.
Exactly.
Thank you for joining us on this exploration into Dr. Opelka's vision for goal-directed care. Keep exploring, keep questioning, and keep diving deep into the things that matter most to you.